First of all, my name is Chin-Kuo Chang. I'm the Associate Professor for the Program of Global Health here at National Taiwan University. My expertise is about epidemiology, so that's why I'm here. But my research interest would be about mental health and also for cancer. But currently, my research topic would be about mental health and also for chronic pain, which is more about neurology. And I'll be your teacher for the lecture about principles of epidemiology. So today I'm going to spend like half of the 2 hours to give you some idea about what's going on, what will happen in the lecture of epidemiology. And in the second hour, I'm going to give you a general introduction about epidemiology, what it's all about. But even if you don't understand anything, that's fine. I'm going to record again and again and again, until you do understand what's going on here. So don't worry if you don't understand. But it might be helpful for you to understand what's going on, what's going to happen in the future. Okay, so epidemiology is generally the core courses, one of the core courses in anywhere you can learn public health, anywhere in the world. So even if your research interest is about quantitative research, you do need to have some background information or background knowledge about epidemiology as the basis of a quantitative research method to understand what's going on in the literature. Okay, so please take it seriously. Okay, outline. So first of all, I'm going to show you why it does matter for disease. What's the meaning of disease from an individual level to the population level? Okay, the meaning of disease could be different. Some disease could be very mild and very common, and some disease could be rare but serious, right? But the meaning will be different from person to person, from people to people. And because we have sympathy, we feel that it's kind of painful, discomfort for the other people got the disease. So that's why even if I'm healthy, I'm willing to know the causes of disease to help the other people. Okay, that's the whole idea. If you are an animal, some animal might care, like an elephant or a monkey, they do feel sympathy. They feel sad when other monkey or elephant got sick. But generally speaking, the animal is not as a human being that we do care the diseases of the other people. Okay, and then I'm going to introduce a classic example, which is so-called scurvy. Scurvy is kind of ancient disease happening in the British mariners in the voyage era, back to the 18th century. It's a kind of the classic example about why the disease happened and how we solve the issues and how researchers figure out the relationship between vitamin C and the occurrence of scurvy. And then we'll go into the topic about the roles of epidemiology and biostatistics in global health in different levels or different aspects. To let you know that what kind of role could be played in epidemiology, how epidemiological method will be helpful for us to figure out or answer the questions which does matter. Okay, so it's what epidemiology is all about. Okay, and then I'll go into the detail about the critical components for the consideration in epi research for different fields. So first of all, some of you might be interested in clinical medicine in the future as part of your career development. But people might think, are they the same or are they different from each other in certain different levels? But generally speaking, public health is more about the population. It's the health or disease of a population. But clinical medicine will be focused on the individual needs, individual conditions. But both of them, the difference will be about the targets. Public health is more about population, right? And clinical medicine will be focused on the individual conditions. But both of them are applying the knowledge about medicine to people. But the purpose could be different. For in a level of population of public health, we care more about prevention and health promotion to avoid or prevent people from getting diseases, right? You might not be able to cope with so many new cases emerging in a population. The capacity of the medical services might not be able to take care of so many people if it happened in a very short period of time. right? But for clinical medicine, we do care about the way to do the diagnosis. Diagnosis is the basis of treatment, right? So if you do it in the wrong way or give it the wrong diagnosis, so the treatment might not work for the wrong diagnosis. And also clinical medicine is very focused on the development of new treatment methods. And so it's kind of different in this way. But specifically, no matter for the clinical medicine or public health, the intervention could be like a spectrum. For some diseases in clinical medicine, we have nothing to do with it. And sometimes it will go away by itself. Yeah. But for public health, the consideration could be totally different. We could do nothing, or we could do a lot of different kind of interventions. So no matter for clinical medicine or public health, there are many, many different kind of interventions. For the clinical medicine, the intervention will be for specific individuals only, right? But for public health, the intervention could be as big as the environment. For example, for the issue of global warming, then the challenge will be totally different. The intervention could be the environment level or the planetary level, right? Or human behavior, which is not so close or so individual level. It could be at the population level too. And lifestyle issues, that's more individual. And medical care, that's for individual level. But the tool we are going to use could be different. But the purpose could be the same, to take care of the people. But there are some overlapping. I mean, the treatment for clinical medicine sometimes could be used for the purpose of intervention for public health. But no matter we are talking about public health or clinical medicine, both of them will involve multiple professionals, not only clinicians. It could be sociologists, anthropologists, for different or people in with the expertise in biostatistics, which is not about clinical medicine at all, right? But in America, you could find a lot of people who got the medical degree first and an MD, PhD in biostatistics. Yeah, so they have some clinical background to have a better idea about what's going on for biostatistics. Okay. So I can raise a lot of tons of examples about the major public health achievement. Yep. The typical one is about vaccination against infectious diseases. And nowadays, it's true that we can prevent the diseases for most of the, not most, at least a certain part of the infectious disease could be easily or mostly controlled by vaccination, like measles, right? But maybe for some other infectious diseases, it's not so true, like HIV. Yeah, but we are trying to develop the vaccination to prevent people getting HIV. Yeah, but vaccination is not a tool for all the infectious disease. It really depends on the entity of the disease itself. So COVID-19 will be a great example of that because it mutates rapidly because it's an RNA virus. So it's just changed over time. So even if we develop some pretty useful vaccines against the Delta, right, COVID-19, but the efficiency or effectiveness just decay because of the ongoing mutation or rapid mutation of the disease, of the virus. So that's about the entity of disease. And also there are a lot more infectious diseases. It's not so easy to develop the vaccination. But nowadays, a lot of fatal diseases like smallpox has been not only controlled and also eliminated from the population. The tool would be vaccine. Okay, so it's pretty successful, but not overwhelmingly successful for all the infectious diseases. And the other example is about the prevention of nutritional disorder. Do you know that before World War II, we don't really have a clear idea about vitamins? But after World War II, we have some more idea about the essential components from food or supplements, which could be helpful to prevent or treatment for some specific diseases. Okay? But with more and more information or knowledge about vitamins, now we are pretty sure that more vitamins doesn't help to prevent any diseases. Right? Vitamin C is kind of pretty powerful to prevent cancer, but in epidemiology research, we have pretty strong evidence in epidemiology that it doesn't work. It doesn't help to prevent any kind of cancer at all. But deficiency of vitamin C will cause a serious disease called scurvy. We knew it. Yeah, we have very strong evidence about it. Okay, so we are going to talk about it later. Yeah, but it's kind of a public health achievement. At least nowadays, it's very rare to find that people got sick because of the deficiency of vitamins. Okay, but of course it happened for the ones with a serious problem or war, refugees, something like that. It could happen. Okay, so here's the example. There's a story about Dr. James Lind. This is a book which is pretty interesting, published in 2005. Scurvy, how a surgeon, a mariner, and a gentleman solved the greatest medical mystery of the age of sail, the voyage era. Because before that, it's pretty unlikely to find someone without food supply from the nature or fresh. Because of the long journey on a boat, so there's canned food becomes something important, something useful. Yeah, and it's not true that the fish is everywhere in the ocean, okay? They only exist in some specific areas, like the west coast of Pacific Ocean. For most of the parts of the ocean, there's no fish, okay? So there's no fresh food supply at all, okay? So here's the story about how Dr. Lind find out the linkage or association of the vitamin C from fresh food, especially for the citrates, to cope with the occurrence of scurvy. If you read the article, the book, you'll find out scurvy is pretty scary, and the symptoms could be serious, ugly, yeah, kill people violently, yeah, cruelly, sorry. Yeah. So this is a typical or interesting story about how epidemiology helps us to deal with the issues of the insufficient fresh food supply for vitamin C. And the other example is about the prolonged longevity, or so-called life expectancy at birth, for almost every single country in the world. Even in North Korea, one of the countries with the shortest life expectancy on Earth. So for most of the country, people live longer. What is the reason? But generally speaking, the major or the most important issue is the maternal and the child health programs. Okay? It's not the improvement of nutrition or the cure of cancer. Because of the improvement of maternal and child health programs, increase longevity. Because the life expectancy is an indicator which is very sensitive to the death at the earlier stage of life. Okay? So if we prevent the premature death, it will make the life expectancy much longer. That's the characteristic of the index of the life expectancy at birth. I'm going to introduce how we can do it with data from a cohort study. Okay, so you will learn it. But that's the major reason, or it contributed the most for the elongation of the life expectancy. Okay, and the last example is about fluoridation of drinking water to prevent dental caries. Okay, how we find that and why we stop doing that. I'm going to tell you the detail of the story in a lecture about randomized controlled trial. That's the origin of randomized controlled trial. Okay, of course, no matter what we do, there's always pros and cons, advantage and disadvantage, right? But the fluoridation of drinking water, there are some advantage and also disadvantage. That's how we developed randomized controlled trial. But the origin will be like that. Okay. About the new challenges for the millennium, the 21st century, the first one is the emerging infectious diseases, like Zika virus, which did exist in South America only. Yeah. But now it's kind of spreading worldwide. What was the reason? We don't know much. But global warming could be one of it, and crowding of population could be one of it. And the other thing is that the virus could be evolving. There are a lot of reasons for that. But it's always challenging. COVID-19 will be another great example. So it's coming up and every single day. Yeah, and Ebola virus is the other one. The fatality rate is so high, but actually we don't know much about it because it comes so soon and disappears so soon. Right? It breaks up without any reason. It's gone without any reason. There's a reason that the people just die pretty soon. They have no chance to spread out. Right? But nowadays we find that the fatality rate for Ebola virus is kind of decreasing. It's also evolving to increase the chance to survive in population, right? And got more chance to spread out. Okay, so generally that's the direction of the development for infectious diseases. And for most of the country in the world, chronic disease and degenerative disease like dementia is one of the major challenges. And it's very or pretty unlikely to prevent at early stage. And people don't really care. If you talk to young people about diabetes, hypertension, they don't really care, right? It's not really useful to try to prevent degenerative diseases for younger adults, right? So the target of the prevention strategy, we might need to focus on the mid-age, like around 50 or early 60s for the prevention of degenerative diseases. But nowadays it become more and more important as the major causes of death in most of the countries in the world, like cancer and cardiovascular disease and metabolic diseases. Okay, but it's pretty unlikely that we could use the strategy of legislation to prevent chronic diseases, like the tax for fat, saturated fat products or sugar. Right? I don't think it's feasible to ban or put a high tax on drinks with sugar or saturated fats. So it's not really feasible. So what we can do, health education would be the only thing we can do. For most of the countries, there is no strong legislation strategy for cigarettes at all. Right? It's a kind of legal recreational drugs. And also it depends on the people's choice. We cannot enforce people to change their personal choices. So it's difficult, but it's important to find a way to change people's behaviors, especially for the lifestyle issues, which is harmful to health in the long run. People don't really care about it. And the other thing is about how to make use of relevant genetic data for public health. It's an issue under debate for a long, long time, because if we know more about genetic characteristics for certain diseases, it might increase the possibility or the strength of discrimination against the people with certain genetic characteristics, right? And also there's some law issues. Is it okay to generate or let people know the genetic characteristics which are related to the possibility of getting a disease? And also the insurance company might be really interested to know your genetic profile, right? To charge you at a higher rate, right? But maybe you don't want the other people to know it at all. So a lot of issues going on. And also it could be religious, right? Some people might think that it's personal, it's something given by the nature, by my God. So what's the point to deal with it? Even if for the sake of public health purposes or disease prevention purposes. Right? So a lot of argument and a lot of the debate going on about it. Okay. And also the other thing could be that is it ethically okay to develop genetic treatment for rich people only? It could be very expensive in the very beginning, right, for genetic therapy. But if it's only affordable for rich people, is it ethical to do it? Yeah, maybe, maybe not. So there's a lot of things to argue, to think about anyway. Okay, but still a long way to go, because up to now in epidemiological researches, we found out that contribution for genetic is very not so strong. The information is not good enough for us to prevent all the diseases by the genetic findings. So it's still a long way to go. Not only the technical issue, methodological issue, and the role of genetic characteristic in the development of diseases is not clear. Yeah, but the only thing we know that is the contribution for each single nucleotide polymorphism is quite small. And the other thing is about resource allocation. That's the major contribution of WHO, right? The purpose of WHO is to get more resources to help the people with the low income, for poor people, right? And rich countries got responsibility for the people for every single one in the world, right? So it's about resource allocation. Okay, for most of the countries, for the middle to high income countries, they use health insurance to take care of people with resources reallocation. Right? For rich people, if they're rich enough, they don't really care about expenditure on medication or health services, right? But for poor people, it could be a problem. And it's kind of the circle that poor people are easier to get diseases and more likely to happen in people with low socioeconomic status, right? They're kind of twins, poverty and disease. They are twins, or at least they are good friends, right? So they might exist together all the time. So countries or the states will be the one who have the responsibility to assign the resources for every single one to take care of them for their health. Okay, but it's challenging because no one wants to pay, but everybody wants to enjoy the benefit from medical services, right? And Taiwan is one of the leading countries with almost a full coverage of the national health insurance. It's very cheap. Okay, it's almost, I cannot say it's free, but it's very low anyway. It only takes like 6 or 7% of the GDP in Taiwan. Yeah, but there's still a lot of issue about allocation of resources. Yeah, like and most of the money was spent at the last 30 days of people's life in Taiwan. So if we prevent those kind of things, to spend too much money on the last several days for people is not really useful. It doesn't really helpful to increase the quality of the treatment either. So it depends. But there are a lot of issues going on anyway. So we're not going to go into the details, but that's something you could consider. How we could make the resources allocated evenly or in a more fairer way. And the last thing is about environment deprivation, especially for global warming, right? Nowadays there are a lot of natural disasters going on. The wildfire in California, right? And there was a big one in Australia last year, right? And also the flooding in Bangladesh. It's almost everywhere in the world. And also it's moving to the north and to the south. In the past it's closer to the equator, but now it's kind of spreading out because of the global warming. Okay, so it's kind of the environment deprivation. It's a very specific important issue about environmental refugees, right? Yeah, so it's totally a very important topic about global health, right? That's the purpose we are here. And there are a lot of important issues going on for the environment or climate refugees. Okay. Also, there are a lot of things to talk about. Okay. In any public health college or school, there's always something called core courses. Epidemiology and biostatistics will be definitely part of it. Okay. So we call it core courses. Okay. It will be very helpful for you if you have some background knowledge or training about epidemiology and biostatistics, which could be applied in very broad of ranges, like occupational and environmental health, the principle and the practice. You'll be able to understand what's going on and how that could be helpful for you to deal with data from environmental occupational medicine. And also, even in the health management, which is about administration, and epidemiology and biostatistics will be very helpful for you to understand how we could make the decision for public health policy in the process of decision making. Okay, I do believe that you will be big guys in the future. Okay, and epidemiology will be the way, or is the tool to provide useful evidence for you to make the public health policy, to make the decision about it. And even for health economics, which is about money or resources, epidemiology will be also very helpful for you because In epidemiology, we emphasize the comparability. If you want to know more about some issue, reasonable comparison is the basic for science. Okay, so you need to construct research with a basic scientific structure to make a fair comparison, and the outcome could be money, right? Then or payment. So it's also about health economics or discharge education. Why we need to do the education, health education for people who are going to discharge from hospital? Yeah? Because we know what will happen if we don't give them, then they might blah blah blah. Right? One of my research topic in UK was about the sudden death after discharge for myopia, for the hospitalization of myopia for people in a hospital, in a mental health hospital in UK. Yeah, they might join the party and then die eventually, quickly after the discharge from the hospital, because the tolerance will change over time. So if they stay in the hospital for a period of time, then the tolerance to the recreational drugs could be lower. Okay, so it's possible, or the risk is high, they might die from the overdose. And especially for emerging infectious disease, which is the expertise of Andre, right? So you've been suffering, no, you've been, sorry, you've been taught or trained by his expertise. His expertise is how to use the biostatistical model to mimic the behavior of infectious disease in a population, right? So not only for infectious disease detection, but also for control. If we change or modify the parameter, how it will change, then we could evaluate the effect of each intervention, like mask, like social distance, right? How we can make the decision about the duration of quarantine, right? It's all based on the modeling research about emerging infectious diseases to help us to make the decision again. And about outbreak management or quarantine policy, like what I said. Okay, so no matter how or which field you are going to do for your dissertation, epidemiology and biostats is kind of fundamental for your 2 years here. Okay, so let's go back to what is so-called epidemiology. Can we define it in a clear way? Yes. Epidemiology is generally defined. If you Google epidemiology, you got maybe a million kind of the definition. Define epidemiology, you find many different kind of. But no matter how epidemiology is defined, there are two important components. The first one is the distribution of disease among the population. And the other thing is about the determinants or the risk factor of the diseases. We need to know the distribution or describe the disease in the population. That's the first step to manage it, right? And then we need to know what's the characteristics to put people at a higher risk or easier or more susceptible to the disease. Okay? What's the purpose of doing that? Because if we know the risk factors, we could focus on the people with a higher risk to prevent the happening of the disease, occurrence of disease among the population. Okay, so that's why we need to know that. But people might ask, what about animals? They got sick too. Do they have epidemiology? Yes, there's a specific field called zoonosis. It's about the diseases among animal populations. Okay, and we apply similar rules in epidemiology. But there are some overlapping between human epidemiology and zoonosis. Because there are some diseases transmittable between people and animal, like anthrax is an example. Ebola virus is the other one. HIV, right? So there we do share some diseases. And do you know that nowadays, what is the major cause of dogs in human society? They are pets, right? Do you know what's the major cause of death for dogs? The answer is very similar to human being. Okay, they got heart disease, they got diabetes, they got cancer too, because of lifestyle issues. Yeah, although they don't smoke, but the pattern are very similar. Okay, they might have a longer life expectancy compared to the dogs in the wild, right? But the pattern of the disease and the pattern of mortality are very similar for cats and dogs living like pets in our human society. Yeah. Anyway, so we follow similar rules to prevent. But it's hard to do health promotion for dogs, right? You have to lose weight, control your hypertension, right? I do know that some dogs or cats are on medication for diabetes. That's true, yeah. And they might have mental issues too, yeah. So there are mental health epidemiology for dogs and cats too, right? Then what is the objective of epidemiology? First one, we need to apply the knowledge we learned or developed by epidemiology to define the disease. You say, what? I thought this disease only defined by clinicians, by the clinical signs or symptoms. Why we could use epidemiology to define the disease? Because for some new diseases, we cannot find the differences. Okay? And the great example is AIDS, acquired immunodeficiency syndrome. Syndrome is a group of the combination of the symptoms and signs. Yeah, so it's not a typical disease. Okay, it does happen before we know anything about HIV. I mean, people might have acquired immunodeficiency somehow because of genetic problem, or it could be because of chemotherapy. It could be because of aging. Okay, but it's so rare. But in the beginning of the story about how we define, how we understand HIV, we find out a group of people who are really unlikely to develop AIDS, they are young, they are not on chemotherapy, yeah, and they are male. Okay, that's not the characteristics of what we saw before. Okay, but epidemiology helps us to find out that there are actually two groups, different kind of disease. Okay, that's the cause of AIDS would be, for young people would be the infection of HIV, human immunodeficiency virus. Okay, so epidemiology was the tool for us to discriminate the old kind of AIDS and the new AIDS caused by HIV infection. Okay, and also epidemiology will be helpful for us to find out the disease pattern. That's important. For emerging infectious disease, there's an outbreak. So it would make the medical services burn out, right? Overloaded, right? And the direct consequence of that is not only about the insufficient capacity to treat this group of people. It could also decrease the capacity for us to treat the people with other diseases, right? And mental health issues. One of our articles, we report in one of our recently reported published article, we found out that during the outbreak of COVID-19, the people with severe mental illness got higher risk of death or general mortality. And most of it is not caused by COVID-19. It could be suicide, cancer, or other any kind of causes of mortality. Why is that? It's because of they are competing for the medical services resources, right? Okay, so pattern does important, and also help us to find out the best way to allocate our medical service capacity. And also we could apply the evidence from epidemiology to estimate the disease burden to the society. That's the expertise of Professor Lin, the director of our program. Okay, his expertise about how to apply epidemiology in estimation or assessment for disease burden to the society, which is also very important. Okay, but for me, epidemiology is a very important tool to understand the disease's etiology. The term etiology means the studies about the causes of disease or risk factors of disease, the reason why people get sick. So that's the etiology. And what's the point to know that? If we know the etiology, we could cut the relationship, causal relationship between the exposure or the risk factor to the disease. Like smoking is a great example. Before World War II, we have no idea about the adverse effect of smoking at all, right? But nowadays we know that smoking is really bad. It increased the risk of almost every kind of cancer and a lot of chronic diseases. Okay, so quit smoking is the best way to avoid getting or minimize the risk of getting those kind of diseases. Yeah. So because of the evidence from epidemiology, we know better about how to prevent those fatal diseases or those diseases with a high burden to the society. So that's for the purpose of the policy making. So epidemiology is very helpful to provide the evidence about it, to generate a public health policy. Okay, but in the aspect of the clinicians or clinical treatments or the consideration of preventive medicine, epidemiology is also helpful for us to evaluate the preventive or therapeutic measures, especially for the study design of randomized clinical trial or randomized control trial. That's the only way we could evaluate, especially for the innovative preventive strategy, because it does not exist in nature, or the new medication does not exist in the nature. So in the nature, so we cannot observe what's going on if people exposed to the material. And also epidemiology could help to support and evaluate the public health policy, like what I said before. Clinical treatment, that's clinical epidemiology, right? Or development of new intervention. We have mentioned that. So here's an example about the disease pattern change over time. Back to the beginning of the 20th century, the leading cause of death is pneumonia and influenza. It's kind of pneumonia caused by influenza for most of the chains. And tuberculosis, which is also an infectious disease. Diarrhea and enteritis, which is a group of the GI infectious disease, right? Heart disease, stroke, blah, blah, blah. Okay? But the top three diseases were infectious, right? Okay. And then what happened in 2014? The top one was heart disease in America. But in most of the other countries, cancer is the top one cause of death. And the second is cancer. Third one is chronic lower respiratory diseases, COPD, which is mostly caused by smoking, again, and accidents, stroke, blah, blah, blah. But no matter how, you could see a dramatic change of the pattern of the major causes of the death, from infectious disease to chronic diseases or degenerative diseases like Alzheimer's disease. Yeah. But there's still some unsolved problem or something still challenging from infectious disease, like influenza. It changes over time, it evolves or mutate rapidly. For most of the country, you could see such kind of disease pattern transition over time. Okay, and here's the, it's pretty famous, almost everyone has seen the post. It's an example from what's happening for the outbreak of the cholera during the 1830 something. If you've ever heard the story about John Snow, it's a note put on the board for the Dudley. It's a small village. Dudley Board for Health. Churchyards at Dudley being so full because so many people died in a very short period of time. The cemetery was full. No one who has died for the cholera will be permitted to be buried after Sunday next or tomorrow to either the burial grounds of St. Thomas or the St. Edmunds in this town. It's so crowded. So many people die in a short period of time. They don't even have space for new bodies. And here's the picture of John Snow, who was an anesthesiologist, which is the first epidemiology in history. Okay, how could someone create a job for me? He did. Okay. And here's another picture, which is interesting that people like to put their hands in their pocket back to the mid-19th century, right? So if you do a better job, I will pay you more, right? I'm ready to pay, do it better, right? But he's the one who created my job. So what he did is generally a very simple comparisons, and it does make sense, okay? So he just found out that if we use the number of houses as the denominator and the number of deaths from cholera from the registration given by the London government, then we could do a very simple calculation of this, the number of deaths, divided by the number of households. Although the number of people in households might vary from 1 to maybe 10. Okay, but generally speaking, at that time, the households are pretty big, maybe 6 or 7. But no matter how, if we do a simple calculation, we find out that for the households whose water supply were given by Southwark and Vauxhall, they are 2 companies, but they combined as one. The death per 100,000 households is as high as 315. For the other company called Lambeth, all of them are now the name of boroughs in South London. Okay, you can find out that the death per 100,000 households was 38, which is almost 1/10. Okay, you don't even need to do any further calculation for the purpose of the relative risk or confounding control. You will know that the difference is so dramatic. So there must be something going on for the water supply company, right? And comparing to the other distincts, is something between them, right? Between 38 to 315. But no matter how, there's something going on for this company called Southwark and Vauxhall for the water supply. There must be something weird or something in the water to cause people get sick. So what he did is just a simple comparison, not much mathematics, right? But the comparison does make sense. Okay, so he answered the questions about it. At that time, people have no idea about bacteria at all. We have no idea. We had no idea that bacteria is the cause of diseases at that time. Okay, so you just do a simple calculation and then figure out that the reason must be about water supply. So how are we going to apply the epidemiology to characterize diseases? Or we could ask the question that why characteristics or combination of characteristics best discriminate from non-disease? How we discriminate people with or without the disease? And that's why I said that the case control study is generally the first step to answer the question like this. We compare people with the disease to people without the disease and see what characteristics make them different. Okay, so we can have a general idea about what's going on for the causal relationship for these factors to the existence of disease status. Okay, so for disease occurrence, if we ask the question, what is the risk of development of the new cases in a population? So in this kind of research question, we emphasize the status change from no disease to having the disease, right? Then the way we measure it is incidence. Okay. If we want to know that what's the proportion of the current disease within the population, the indicator we need to use would be the prevalence. Okay, this is common sense, right? So it's about the existing status of disease within a group of people. Then we call it prevalence. And what are the influences of age, gender, time, and the geography on the above for the incidence or prevalence? The way we do it is the so-called descriptive epidemiology to characterize the disease at the population level. So the purpose of that is trying to find out the disease causation, the cause of it, and it will be better directly correlated to each other for the judgment of causality. So the question is that what are the risk factors for disease development and what are their relative strengths? There are many risk factors, right? I want to prioritize or I want to measure which one got the strongest impact to the status change or the risk. And the way we do it is so-called analytic epidemiology. So we step forward trying to find the quantitative estimation of different kinds of risk factors. Which one is stronger, which is more important, which one is more common in the population. Then we could prioritize about our policy or intervention. Okay? So relative risk is generally the way we do it. So we could simply do the calculation by the incidence of disease among the exposed ones divided by the incidence of disease among the non-exposed ones. Right? It's very intuitive, right? It does make sense. Or you could calculate the differences. The I is incidence of exposed and minus the I incidence of the non-exposed group. We call it attributable risk. We could do different kind of calculation. No matter how, the relative risk is high then we could know that the people with the exposure is very, very dangerous. They are at much higher risk. Or the differences of this, the exposed one minus the non-exposed one is very high. And we also have some idea that the impact is so strong and people with exposure got much, much higher risk. Right? So both ways would make sense. But in terms of methodology development, nowadays we prefer to use the relative risk in epidemiology. Okay? So we are mostly focused on the relative risk as dimension and how we evaluate the relative risk for different kind of study design, no matter core study, case control study, and randomized control trial. We use the relative risk for the most. Okay, so if we consider for example, chronic disease as the exposure, like diabetes, you don't feel a thing. In the early stage of diabetes, you don't feel anything. And 200 years ago, we have no idea that there's a sugar or glucose in our blood at all. It doesn't taste sweet at all, right? Yeah. And we have no idea about the meaning of glucose level in our blood 200 years ago. Yeah. But we do observe that some people, they just lose weight dramatically and they eventually die, even they are young kids. Now that we know it's type 1 diabetes. Yeah. But in the past, we have no idea about it at all. But if we consider it as exposure, I mean diabetes as exposure, then we will know what happened if we don't do anything for the prognosis of the diabetes as an exposure. So the question is that what is the outcome following disease onset? We can give a definition about the glucose level. If the fasting glucose level higher than 100 or HbA1c higher than 6%, blah, 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 we could define it. And what are the risk factors for a bad outcome? The worst one would be death, right? And the other one could be blindness, could be kidney, end-stage kidney diseases, etc., include their relative strength. Then that's the issue we are going to answer by clinical epidemiology. We want to know the prognosis. Okay? Then the role of disease here will work like exposure rather than the outcome. And we now consider the prognosis as the outcome. So that's clinical epidemiology about. Okay, for the purpose of disease management, generally the question we're asking is, what is the relative effectiveness? How well the intervention will change of proposed the therapeutic interventions, including health service delivery options, even if it's not directly treatment for the disease, even if it's just about health service delivery. Then we use randomized control trial to evaluate or assess the effect of the relative effectiveness for a certain intervention. So we use different study design to answer different kind of questions for different purposes. Okay, so for the purpose of disease prevention, that's the question we generally ask. What is the relative effectiveness of proposed preventive strategies? So in other words, the relative risk will be less than 1, or the attributable risk will be minus, then the intervention works, including screening. The purpose of cancer screening is to identify new cases at the earlier stage, right? And the purpose is to prevent them from death or advanced stage of cancer diagnosis, right? Then we use applied epidemiological methods to deal with it. Okay, so we develop different kind of study design to deal with it. So if you want to know the prevalence of disease and the potential associates, the reasons, correlation, then we perform survey. Survey is generally cross-sectional. We measure the exposure and the outcome at the same time point to save time and money. But of course, it's not very satisfying because we have no idea that exposure happened before the disease or the unwanted adverse outcomes. If we want to know the risk factor of disease, we could measure the risk factor of the people, a specific group of people, and see what happened in the future. This is so-called prospective studies. The key point is that we follow up this group of people to make sure that the risk factor exists before the occurrence of disease. Okay, so it's about timing. We know that it happened, exists in the very beginning without the disease, and something happened, something developed during the follow-up period. Okay, so it's about timing. Or we could do a case control study. We could simply compare the people with and without disease and measure the exposure. We're pretty sure that something doesn't change for the most of people, for gender, for example. And for genetic characteristics, generally they don't change from the birth to death, right? But case control study will provide us a methodology to screen the risk factors in a very short period of time. And also that's the first step for most of the studies, like HIV. Before we identify HIV, we just compare the people with AIDS at a young age to the other group of people with similar characteristics and find out they got, it might be a sexually transmitted disease, okay? So we know it from case control study. Even if we had no idea about HIV, the virus at all, at that stage. Or if you want to do studies about the prognosis of the consequence of diseases like diabetes or hypertension, we use cohort studies. Now that's very straightforward and easy to understand and intuitive, right? So it really depends on. If you want to develop the methodology of the new intervention, if you want to see if it works, like the development of the vaccination, then RCT will be the only way to prove it. Okay, but no matter how, there are so many different kinds of the study design. How can we judge it? Believe me, if you pay attention to the epidemiology studies published in even top journals, you can find a lot of things going on that they just give it the wrong name of their study design. It happened a lot. They just said, oh, this is blah, blah, blah kind of study design, which is not true. Okay. But I can give you a hint about how to judge it. The key point is to check the timing of the measurement. Okay? So if we look at the thing in a retrospective way, which means that we know the outcome of disease status, okay? And then we just try to trace back about what they exposed before they got the disease, or at the same moment. That's so-called retrospective, look backward. Okay, so if in the very beginning they got the exposure status, but none of them got the disease, and then we follow the investigators, follow up the group of people for a while, and some of them eventually got the disease, and some of them still remain healthy. Then we could compare the rates or incidence between the exposed group to the non-exposed group. Then there's cohort study or prospective study. But sometimes we just use the information from the records. Then it could be retrospective cohort study. Okay, but don't worry about that at this stage. Okay, I mean that could mix up, or you could combine in different ways. But don't worry about that. I mean the retrospective side could be cohort study, and the prospective side could be case control study. I'm going to tell you why, but you don't need to worry about that. But I can tell you that the best way to judge the study design is timing. Try to find out the timing of the measurement. Okay? Then why is it important to have a clear idea about study design? Because it is the essential information for us to decide how we are going to analyze it. So it's about statistical analysis methods. Okay? So that's why it's important. If you do it in the wrong way, you just choose the wrong statistical analysis. So you lose some information, or your article will be rejected, or you will fail in the midterm or final examination, right? You choose the wrong methods. Okay, so there are some essential components for study design. The first question is to ask, what outcome measure is the most appropriate? How can we get the correct or the information closest to the correct one? And what approach should be used to obtain the outcome required? Methodology. So that's why the section in any epidemiology article got the most portion of it, right? It takes the most part of it. In epidemiology, we do care a lot about methodology. Okay, and it's also very important to identify how they do the study population selection to answer the question you raised in hypothesis. When should be studied? How you define it? And how many should be studied? That's a little bit advanced in biostatistics and epidemiology, which is so-called power calculation or minimum sample size required. This is a little bit advanced. So if you take the course about the course of quantitative research method in global health, I'll give the lecture about it. Then what kind of information we should gather? Then you have to focus on the question that how should the information be obtained? To ask the person himself, herself, himself, or you could get the information from medical records, for example. And is the information obtained correctly? If you ask them, they might give you the wrong answer because of he or she doesn't remember. Or he or she might exaggerate the exposure because the disease status, we call the recall bias. We are going to mention it. So if the information given correctly, then we could say it's a high validity. Or if you do it repeatedly and find exactly the same answer, that's a high reliability. So in the lecture about the screening, I'm going to show you how to consider the whole thing about validity and reliability and why it's important to evaluate how good the measurement or screening tool is. Okay. And the other key issue for any consideration of epidemiology is bias. Bias is simply defined as a systematic deviation from the truth, which is that bias is the wrong answer, but it could be different direction. It could be lower or higher. Okay. But there are many different kinds of biases, like selection bias. You don't need to worry about the term here at this stage. But I can tell you that the selective sample does not necessarily cause selection bias. Okay, you just need to know that. Okay, if you find a very specific group of people for your research, there could be different kinds of biases, right? But selection bias is not necessarily happen in that kind of situation. I will tell you why, so don't worry too much. Well, non-response bias, that's a kind of information bias. People just selectively don't give you the answer or refuse to join your research. That's information bias. Or ascertainment bias, it's also information bias. So you can see many different kinds of terms about biases, but it's not really important to remember the name. It's more important to identify those biases and try to avoid it at different stages of the study. Or subject bias, or so-called Hawthorne bias. But no matter what kind of biases, the most important one is confounding. I can tell you that 80% to 90% of efforts for epidemiologists or investigators in related fields will be confounding. We'll try to avoid or prevent or deal with confounding. Most of the efforts for epidemiologists is about it, and many more. It's not important to remember the name of the bias. It's more important to learn how to identify them and how to avoid them. Okay, so this is the last slide. I think it should be one of the last slides about the role of epidemiology in global health. The reference is given here. This is a qualitative study by interviewing global health teachers in German medical education. So they are the ones who give the lectures about global health. The title is Global Health as an Umbrella Term. Okay, and here is the development or the origin of the idea about global health. In the very beginning, the origin of epidemiology is about infectious disease, right? And during the colonial era, imperial countries spent a lot of money and efforts to do the research about tropical medicine or so-called hygiene to prevent the diseases from tropical areas for the purpose for invasion and also to protect themselves. At that time, epidemiology is mostly about how to prevent disease from the tropical areas. But development along with the time, there are more events happening. Then we combine the ideas from public health, anthropology, and sanitary health. And in the past, during the Cold War, it was called international health. But now we expand the idea to involve the ideas about tropical medicine, anthropology, and public health to generate so-called global health. Okay. But now more and more issues about the climate change, about globalization, and now there's a new term called explanatory health to consider the whole thing at the planet scale. So the idea is changing. Okay, so that's it. So I can show you that that's my style. So almost every lecture, in the end, I'll give you the personal insight, just my personal feeling about the topic. Okay, after 2 decades of research and so many years of teaching, I have some idea about it. It's kind of a rule of thumb or empirical thought about the topic. Okay, and I will focus on or repeat the key points again. I'll read my lips. Generally, that's the source of my idea about midterm or final exam examinations. So read my lips is kind of repeat the key points again to highlight the importance for the topic. And ways to think is sometimes we could do the discussion in class, or it's some kind of material for you to read, to think at home, or you could talk to your friends or maybe your family online. Vaping linked to COVID-19 risk in teens and young adults. Okay, let's think. Let's read the article and think together. Okay, the topic, vaping. You know vaping? E-cigarette, right? It's like smoking. Cigarette smoking and e-cigarette is vaping. Vaping linked to COVID-19 risk in teens and young adults. The subtitle, data collected in May shows that the teenagers and young adults who vape face a much higher risk of COVID-19 than their peers who do not vape. Okay, so the comparison groups are pretty clear, right? Vaping and non-vaping. Stanford researchers found. Stanford is the top medical school, right, in America. Yeah. But whenever I read the news and it just try to show the authority desperately, I start to worry about the contents. If a man wants to show how outstanding he is or how rich his family is, then you start to worry. You might need to reconsider that person, right? Anyway, so that's the structure of the news. In the very beginning, they highlight the most important thing, right? And then 2 is equal to 1 plus 1, and it gives the essential details in the following part. Vaping is linked to a substantially increased risk of COVID-19 among teenagers and young adults, according to a new study led by researcher blah blah Stanford School of Medicine. And this study, which was published by online August 11th in the Journal of Adolescent Health, and is the first to examine connection between youth vaping and COVID-19 using USA population-based data collecting during the pandemic. Wow, population-based. Do you know the size of population in America? 300 million, more than 300 million. Yeah. So I'm wondering how they could perform a population-based, right, study. That's the first thing pop up in my mind. Among young people who were tested for the virus, that cases of COVID-19. See, they are the group of people who tested for COVID-19. Why? Why they want to test if they got the COVID-19 infection? Because they got some symptom, right? Or they do it for some purposes, or they exposed their family or their friends got the COVID-19 infection, right? So are they really population-based? Another question. Do they really reflect the situation for all the teens and adolescents who are vaping or not vaping? That's a question, right? Okay, why they need to do the screening? That's the issue. Okay, among young people who were tested for the virus and that causes COVID-19, the research found that those who vaped were 5 to 7 times more. That's the idea of relative risk, right? Like what I said in the previous slide. Likely to be infected than those who did not using the e-cigarette. So the comparison scenario is pretty straightforward, right? It's clear. But the issue is about why they only use the people who screened for COVID-19 for the purpose of research, right? Quotation mark. Teens and young adults need to know that if you use e-cigarette, you are likely at an immediate risk of COVID-19 because you are damaging your lungs, says the study senior author, Bonnie blah blah blah, PhD professional of pediatrics. Is it too early to make the conclusion that vaping is hurting your lung, which cause or change or increased the risk of COVID-19 infection? Maybe not so straightforward, right? It's kind of gap. They jump from here to there, right? Vaping hurt your lungs, so you got a higher risk of COVID-19, which may or may not be so true, right? Intuitively, you might be right, but you think the topic through. Here, we will find some idea, some information about so-called population-based. Data were collected via online surveys conducted in May. Surveys were completed by 4,351 people. So how can they make sure that the 4,000 people are represented to the whole population in America, right? And also it's done online survey, right? So it's a really big question mark about so-called population-based data source, right? And ages 13 to 24 who live in the 50 US states is not enough. Even if they from each state got some subjects to join it, it's not necessarily true. The sample here for 4,000 people is representative to all adolescents in the USA, right? The District of Columbia and 3 US territories. Well, that's impressive, but it's not convincing, right, for the representativeness of the sample. The researcher recruited a sample of participants that was evenly distributed between those who had used e-cigarette and those who were never used nicotine products. Okay, they just tell you that the people who are using e-cigarette compared to the people who don't use e-cigarette, they are similar to each other. Okay, but it does not help to increase the representativeness of the sample. The sample also includes the approximately equal number of people in different age groups, adolescents, young adults, race and genders. So it's trying to answer the question about comparability, right? So generally speaking, they are comparable to each other. That's what they want to say here, right? But actually, a lot more effort has to be done to make sure that they are really comparable to each other. We call it confounding control. Results are adjusted for confounding factors, okay? So they do a lot of things to make the adjustment for age, sex, LGBT status. Is this really related to the risk of the COVID-19 infection? I don't think so. If you have some idea about confounding, there has to be the factors working as independent risk factors. Yeah, so it's not so straightforward about why they use LGBT as one of the confounders. And mother's level education, which is indicated for socioeconomic status. Body mass index, okay, maybe. Compliance with the shelter-in-place orders, okay. Yeah, it might be important, right? And rate of COVID-19 diagnosis in the states where the participants were residing. Okay, but this information is kind of group information, aggregation, not individual level thing, right? But it might be important. Okay, but anyway, they try to measure the factors, make them not really comparable to each other, and try to control it. Okay, that's okay. That does make sense. Young people who had used both cigarette and e-cigarette in the previous 30 days were almost 5 times as likely to experience COVID-19 symptoms. Do you know that for most of the people who use e-cigarette, they also use cigarette? Yeah, all the time. So they are actually very similar thing. And then let's move on. And they had used young people who vaped or smoked or both were 2.6 to 9 times more likely to receive COVID-19 tests as non-users. See? So isn't it the source of so-called selection bias here? Okay, but anyway, you could read the rest of the article yourself. But my question is that, why don't they ask anything about the usage of masks? Have you ever seen anyone who wearing masks and also do the vaping? Right? So why did they ignore the most important thing, which is should be definitely a very important risk factor for it, and make sure that they distribute it evenly between these two comparison groups, vaping and non-vaping. What about the usage of masks, right? Think about it. Right? If they consider the whole thing thoroughly, why they don't measure that? So no matter how, a lot of issues to talk about and think about according to this kind of impressive or dramatic outcome from the news. So that's it. So, great timing. Okay, thank you.